Ah, capito, 5 alla volta. 20. Cosa diventati 20?
Ora 22.
Imbroglio. Non faccio altri due. Non ci
No,
facciamo.
secondo me adesso è l'orario di inizio, quindi si iniziano a collegare ora. 24, stanno salendo.
So I think we will start.
Okay, ready to go?
Yes. So good afternoon from Morocco. Good morning. Good afternoon and good evening wherever you are. We hope that you enjoy your day and you are safe. Welcome again to the 35th edition of the Morocco webinar series, the last one of the 2020. Thank you for attending and following all our webinar series, and thank you to allowing us to share all these days with you. Welcome to all speakers, our eminent and well-known neurosurgeon, Professor Paolo Cappabianca, well-known endoscopic and school-based neurosurgeon, and welcome to my friend and colleague, Professor Adyl Melhaoui from Morocco. Welcome to our panelists, Professor Beverly Shizaram, Assistant Professor in Nairobi, Kenya, and active member of both WFNS Young Neurosurgeon Forum and CANT Young Neurosurgeon Forum. And welcome to Professor Mufid, Head of Department of Neurosurgery in Oujda, East of Morocco, and board member of the Moroccan Society of Neurosurgery. On behalf of the Moroccan Society of Neurosurgery, welcome to all participants. Good evening, Professor Naji Al-Abadi. Good evening, Professor Al-Hakim Al-Khdar. You have the mic. Professor Al-Khdar,
yes.
Give word? Yes.
Good morning, good evening, good afternoon, everybody. So this is the last webinar of our 2020 Moroccan Society of Neurosurgery webinars, and thank you, Professor Cappabianca, for being for having accepted our invitation to talk about pituitary surgery through the last 2 decades. Thank you, Professor Adyl Melhaoui, an expert in radiosurgery in Morocco, for your participation with a talk about the radiosurgery of pituitary adenoma. Thank you, Professor Beverly Cesarem, Assistant Professor in Aga Khan University in Nairobi, Kenya, and for Professor Faisal Mufid, the Head of the Department of Neurosurgery at the University Hospital Center of Oujda. Thank you, Professor Abadi. I hope she's doing well. She couldn't be with us in the webinar. I think she will give you word, but she is not. She's ill somewhat, and I hope she will do as soon as possible. She will do well as soon as possible. And without delay, may I ask Professor Abadi to say some words?
Thank you, Professor Al-Khdar, but I'm really very tired, but I will try. We know that we are in the last webinar. It's 34th webinar. It's a lot of webinars that are doing, and I hope that we reach our duty that it will be to continue our education during this hard time. And maybe Dr. Hudarqawi will give you in the end of this webinar all the statistics and data about how many participants, how many speakers, how many panelists we had have for this series of webinar. So thank you for everybody for their effort to continue this weekly webinar. It's not easy task, but all the Moroccan society and all friend neurosurgeons from Morocco and from around the world help us deeply to succeed achieve to this task. So I think Dr. Delqawi, there is who will introduce Professor Cappabianca. Who you want me to do it?
Excuse me. Yes, if you want. Or what?
Is
Excuse me.
you need to introduce Professor Cappabianca.
Yes, I will be. It will be my honor to introduce our master, Professor Paolo Cappabianca, well-known neurosurgeon and inventor in the field of neurosurgery. He is honorary professor and chairman of neurosurgery and member of the Department of Neuroscience and Reproductive and Odontostomatological Science. He is also honorary professor of Beijing Neurosurgical Institute and secretary of the Italian Society of Neurosurgery, organizer and faculty member of many national and international congress and workshops, mostly focused on the endoscopic, pituitary, and skull-based surgery. So there is his long career. He published more than 40 books, chapters, and I have the pleasure to read many of them, and more than 450 articles in international journals. He is also editor of 5 international textbooks of neurosurgery. He is among the top Italian scientists, and for all achievements, he has been awarded of a Medal of Exceptional Service to European Neurosurgery on the occasion of the ENS 2018 at Bruges. Please, Professor Cappabianca, thank you for being with us, and please share your slides and your science. Thank you.
So thank you very much for your kind presentation. Thank you to Professor Naja El Abadi, who was asking me to give my contribution. And for me, it's a true pleasure, believe me. Every time I have shared our experience with someone, I have learned from other people. So it's a privilege for me. And I want to tell you how we have gone through these 20 years. Okay. This is Naples. You see the volcano Vesuvius, and it's a painting from Andy Warhol, a famous artist. And the evolution of our surgery is some way parallel to what we have observed in history. You see, the ancient Egyptians, just not to disfigurate the face of in the mummification process, were having the brain coming down through the nails with a sort of transethmoidal approach. And this is Cushing. He operated in this way, just opposite to what we have done with the brilliance imaging and with the microscope. But the last evolution is the endoscope. And the difference is that you and all the people in the operating room looks through the screen. And to be able to correctly perform the operation, we need to understand that what we see from below, here you see the cell above the cell laterally to the cell, is just the same as what you see from above. You just have to get used to understand the same anatomy. And has been a journey. I've told you, we started with the microscope and then we kept going with the endoscope. 3 basic steps we need to understand perfectly the anatomy, to have proper instruments to work with, and the surgical technique. The anatomy, we are grateful to Manfred Schabischer and to Albert Roton. You know that he has studied this aspect. This is Manfred Schabischer in the University of Bayern. And this is my friend Paolo Castelnuovo. It's a great ENT surgeon who taught me the secrets of the endoscope. We didn't know the endoscope at all, and has a great knowledge of anatomy. And you see, also our young co-workers have always gone to this magic place at Institute of Anatomy to learn and to make endoscopic dissection, anatomic dissection, painstaking work. So the second aspect, instruments. When we started, we didn't have the proper instrument to reach the target and to work in a correct way to the target. So we have also designed some instruments to better perform the operation. And the first instrument obviously is the endoscope. And also the endoscope has had an evolution. This is the 3D experience that in our hands has not been very fruitful, while the 4K resolution offered by the new cameras is greatly enhancing the possibility of the surgeon to look properly on the target, on the proper target. And then the technique. We have divided the technique in 3 steps: nasal, sphenoidal, and cellular step artificially, but you have to do the things correctly each time. And this is the entrance to the pituitary, the cellular floor. You see is bounded by the carotid protuberance, above it the optic protuberance, between them the optocarotid recess, that's the clinoid seen from below, and above the planum sphenoidale, below the clivus. If you know these aspects, it's easier. You see here, just at the opening of the dura mater, the curette can enter, and laterally you have the cella, the optic protuberance, carotid protuberance, clivus above, and clivus below, and planum sphenoidale above. You don't have always all these landmarks, but as many more you have, the safer is the operation. And you see here the correct 2 instruments. So this is important because this is a microsurgical attitude we have learned from our teachers when we have been using the microscope. Always the visualization is different, but the technique and the way you manage the area, you see how beautiful are these images and close to the relevant anatomy, but the strategy to use 2 hands has not changed at all. It's the contribute we have given to the ENT people who were very skilled with the endoscope, but were using just 1 hand. They were used to have the endoscope in the non-dominant hand and the instrument in the dominant hand. And then the criteria. We use this kind of surgery for non-functioning pituitary adenomas, for SCTH secreting pituitary adenomas, for GH secreting, together with also some drugs that complement our work, and we complement their work. And also with the PRL secreting, because there are, I would say, 15% not responding to medical treatment when there is a mass effect with chiasmal, with optic nerve compression, and in people also with macroprolatinomas who don't want to have life-lasting therapy. So another condition which is good for this kind of surgery is pituitary apoplexy, that neurosurgical emergency, I would say. The goals of this kind of surgery is relief of mass effect, normalization of hormonal hypersecretion, restoration, if possible, of normal pituitary function, prevention of recurrence, and the sampling for tissue diagnosis first, and for further studies, because the future is always in the understanding of the key mechanism of the cells. But with this kind of work, we could understand that the horizons in front of our work could expand, because we were operating here, but we could also see above, below, and laterally to the cellular target. And this had already been understood by Marty Weiss in 1987, a traditional transphenolial surgeon, very clever, very didactic. I had the privilege to know him in Los Angeles, but the standardization of this extended approach, we need to thank this duo, Amin Kassam, neurosurgeon, and Rick Carrao, that is a very friendly and skilled ENT surgeon. And we have been able to use this approach for all these pathologies with the different surgical models: transcribiform, transtuberculum, transpterygoid, and the transclival. You see here, this is the transtuberculum transplanum. Here, you see, this is the area we have to open first of all on the bone, and gives the possibility to this is for below the sella for clival chordomas. But always what's important is that you should well know the configuration of the sphenoid sinus, the position of the cranial nerves, if vessel encasement is present, and the biology of the lesion. You have not to make magic strategies if the biology is against the possibility of a safe removal. And you see that in our experience on more than 2,000 cases, 3/4 of them are adenomas, and then craniopharyngiomas, meningiomas, chordomas, other conditions. For adenomas, we have understood that we could also go above the sella, making a removal outside a sort of cleavage, pseudo-cleavage plane. And we, in one of our articles, we said size doesn't matter because it's important more than the size, the direction of growth of the tumor. If there is a vessel encasement lateral to the carotid, the condition is completely different. But if there is a situation like this one in the painting, even giant adenomas can be managed safely. And with a sort of extracapsular dissection, you see here, this patient, we were able to go above the sella. You see here the optic chiasm, here the optic chiasm, the pituitary stalk. We made the dissection of the capsule. You see always two instruments working in on the target. And these had been in some way conceived some years ago, but now I don't like to say routine option, but it's a possible. You see here the chiasm, the pituitary stalk. It's a very beautiful image. And then this is postoperative view. You see the pituitary. It's really beautiful to see this post-op control. What has really changed the strategy for craniopharyngiomas in our experiences are just the extended approaches. And we have, together with the group of Bologna, we have collected a big series, and we have also gathered an international consensus that this is the approach for infra and suprachiasmatic craniopharyngiomas with midline extension without lateral encasement. Also for retrochiasmatic and even intraventricular. And I'm going to show you some cases. You see this one, the preoperative image, the postoperative image. And this is a case, you see that you open the dura, you detach the arachnoid around the tumor, and then it's possible with starting removing the tumor and dissecting the tumor free from the structure of the base. You see here also with the cavitron, it's possible to make a safe removal of the lesion with respect of the mammillary bodies you will see at the end and of the floor of the third ventricle. It's really, I think, a great emotion. Now, these are images that we see quite often. You see the respect of the floor of the third of the ventricle with the choroid plexus. I think it's really impressive. And then meningiomas. The strategy has not changed. According to Osama Matthews, he said the 4D rule: devascularize the tumor, debulk the tumor, dedress from the arachnoid, dissect from the brain. And it's like, believe me, it's like making a convexity meningioma surgery. You see here, because you turn upside down the idea of the operation. And you see that the first thing you make a devascularization. And this is our recent contribution together with a group of San Francisco, and we tried to give a score considering the tumor score, the canal score, the artery score. But look here, as I was telling you, the importance of the sphenoid sinus, no vessel encasement lateral, chiasma compression. This is a proper case for this kind of surgery with better results on the optic apparatus. And you see here that when you make the early devascularization, also the removal of the tumor quite often is very easy. The tumor comes down, sometimes looks like an adenoma. And you see, you have not touched at all the inner structures, the chiasm, which makes the possibility to have good visual outcomes more frequent. But we have learned in these cases that possibility of vasospasm is crucial. So we always make anti-vasospasm treatment after surgery. Another condition is chordomas. Again, we have here collected the experience with these groups in Italy, and it's an important series of 78 chordomas. And here we have said the rule of three, because in the upper part there is a third cranial nerve. In the middle part of the gliosis there is a sixth cranial nerve. You see here the entrance in the Dorello canal, and the 12th cranial nerve. And the transclavial approach, even if there is a dural invasion, a case like after surgery, postoperative control, it's really impressive again. This is a case here, a video clip of this surgery. Again, always microsurgical aptitude, always two instruments working on the target. And when there is a midline direction of growth, it's the way in our experience. And it's possible, as Al-Mefti says, to remove the infected bone in many cases radically. Then comes the need to reconstruct. It's not a minor part of the procedure. It's a very important part, because at the beginning of our experience, CSF leak, especially in extended approach, was not adequate. And we have made many attempts with multi-layer reconstruction. This has been very important, because the Argentinian guys made this technique, Haddad Bassagastelli, of the nasoseptal flap, that has been popularized by Amin Kassam with a huge series. And now we have made use of both nasoseptal flap, but you see, we first seal the cella with fat in a sort of cork position, outside and inside. Then we put the flap over it, and that's the closure. But we call it 3F technique because we make a CT of control CT the day after surgery, and if everything looks right, we put the patient out of bed immediately. So the fat inside, the flap, the nasoseptal flap, and the flush removal of the patient out of the bed. This kind of work has put us in a strict connection with the other world, and also given us the possibility to work with endocrinologists, with ENT surgeons. I told you Paolo Castelnuovo, Rick Carrao, Ernesto Pasquini, David Kennedy, Heinz Stambergen, Aldo Stam, Vijay Anand, with the maxillofacial surgeons, with our friends anesthesiologists, with the pathologists. This cooperation has been very fruitful, and about the future, no doubt is in the teamwork, but in my opinion, in our opinion, is in the cell the way to do the best thing for our patients. Thank you very much.
Thank you, Professor Cappabianca, for this outstanding and inspiring talk for all of our participants, and especially for young neurosurgeon. Thank you so much. So I don't know if there is questions from the floor for Professor Cappabianca, or we may let discussion by the end of the second talk. I don't know. I will let a few time for our colleagues to think about the questions. Yes, Professor Abedi.
Just to, I would like to thanks again, Professor Cappabianca, for this wonderful, amazing, and overview endoscopic approaches and different tumors. And all of us around the world knows that you are one of the inventor of the set instrument for this approach. It's take your name, Cappabianca set, which we are working with in many departments. And my questions is today, after this superb journey in endoscopy, what do you think about some indication for some tumor, example, for the meningiomas of anterior skull base? Did you continue to indicate this approach? I mean, in below, even if there is the CSF leak is it's still a little bit higher than intracranial approaches. What do you think? I know that there is others endoscopists. Last time we have had with us Professor Fred Gentili, and he told us that he given up to use the endoscopic approach for example, for meningioma of anterior skull base. What's your opinion in this matter, please?
Allora, I think we have not to have a dogmatic approach to what we do. So it's not religion. It's not religion here. It's the best work in the for our patients. I think that this approach is really, there is not anymore the CSF leak rate higher than transcranial approaches. The problem has been, I would say, has been solved as it can occur also in transcranial approaches. Somewhat the incision is not as good as you like and is protruding. But coming to the strategy, we use it for midline lesions. When there is a optic nerve compression, we don't use if it's lateral and there is a vessel encasement. And another we use when there is a downward extension of the tumor, which cannot be managed as well when you come from above. We use also for more anterior meningiomas than tuberculum cell if there is olfactory damage. So there is indication to use more than one way, but we are using with real satisfaction, mainly for the visual results.
Okay. Thank you. And maybe a last advice for young neurosurgeons who want to be the beginner for this approach. Did you have some tips or tricks for them?
No, tricks with experience and work with having someone at your shoulders that can give you the proper suggestions. And as we have told, there is no secret. Anatomic dissection, study, painstaking study and work, and this gives the results.
Thank you. Thank you. Thank you, Paolo. Thank you for this wonderful talk and your participation with us.
Grazie. Thank you, Naja.
I think we have more questions. Professor Beverly, you have questions?
Thank you, Fahad. Thank you for the honor of joining. I'm joining from Nairobi, Kenya. And thank you, Prof. Al-Abadi, for the invitation. Prof, if I may ask, if I start on a light note, if I were, what is your favorite instrument when you're doing the endonasal approach? What's the instrument that you must have on your set?
I have the brain to do the proper thing. No, that cannot be suggested. Among my co-workers, there is one, I don't mention who is, but who has always the right distance to the things, to know when you can do more and when you have to stop. You know, my friend, I think that this is a natural quality. And then the second important is to study, because if you have the culture to understand what has happened and where you are going to, this makes possible progresses.
Thank you. And the second question I had was the transphenodal approach and working around the pituitary, particularly if you have female patients, there are questions around fertility. What advice or counseling do you do, and does that change your approach?
It depends on the condition. You have to respect the importance to have a good endocrinologist and to have proper respect of the gland, because yesterday we did some things and it was all. Today, after surgery, our judge, it's not ourselves, it's the endocrinologist who tells you have damaged one axis, two axis, or so. To respect my friend Dan Kelly in Los Angeles, he says you have to treat the pituitary with TLC, tender loving care. That's the secret.
Okay, thank you very much for. And the other question that I wanted to ask is, when you're starting out, sometimes through inexperience, you've shown a lot of macroscopic resections. Are there things that make you limit, particularly in pituitary adenoma non-functioning, that make you say that it's okay to leave some residual, or do you always do a macroscopic resection?
it's also important the biology, you know, because sometimes you think you have removed everything and the control is not as you expect to be. So the balance, it's natural. The eyes permit you to see where you are. With the endoscope, this is a very good possibility. But you have to know many things. As a matter of fact, if you don't make the removal below and then laterally, but you immediately go above when you have a suprasellar extension, sometimes the system falls down and segregates parts of adenoma. So you have to do the right thing at the right moment. And that's all. There is not a magic thing that you can tell in any patient, in any case, and that always works. And then another thing, the adenoma is a benign tumor, but we have known that also if with some landmarks like Ki67, sometimes you have a high Ki67 and there is no recurrence in 10 years. Other times you have 1% Ki67 and after 2 years you get recurrence. So we have to study and to learn more. It's not only question of doing the proper thing at surgery. You have to do the right thing at surgery, but that's not all. You have to understand what you have done.
And my final question, there's the side effects or morbidity from going through the nose. What advice would you give us when we're starting out on how to reduce the morbidity from nasal complications from doing this approach?
You need to have a very good ENT surgeon, because there is also the need to take care of this patient with inspecting when necessary after surgery, the proper controls to avoid synechia, if you have the proper care, and if you look at the complications you have, you understand as many you have and what is the thing to do if things don't go as you would expect.
Thank you very much, Prof.
Thank you.
Thank you. Thank you so much. I think we have a question from Professor Yesad Wadghiri, and then maybe Professor Faisal Mufid.
Okay. Good evening, everyone. I don't know if you can hear me. Is that okay?
Yes.
Okay. So a very nice talk, and thank you, Professor Cappabianca, for this really reappraisal of the endoscopic on the nasal approach. I had two questions, if you permit. The first one would be on how often do you go for an extracapsular dissection, as you've shown on the videos? I mean, opening the supra-diaphragmatic cistern and go for a total removal in the case of macroadenomas versus intracapsular dissection and decompression. This is the first question. And the second one would be on your experience regarding the paraseptal or the transseptal approach for the on the nasal route. Did you find any difference, any functional difference during your experience? That's it. Thank you.
Allora, so the first question, it depends on what you find during surgery, because sometimes based on the consistency of the lesions and on what it comes at the end of your removal, if you see that the cistern has come down, that you have no remnants laterally, it's enough. Sometimes you see and feel that the result is not good. And sometimes, as a matter of fact, you can have bleeding, and so removing the adenoma, which doesn't stop. Usually, when you make good removal, the bleeding stops immediately. So, in these cases, we put a cottonoid inside the cella, remove the bone above, and go for extracapsular. Sometimes you expect you have to do this, but we always try to make safe removal without extra capsule. And the second, with the experience, you make many different options. You have seen we have made the reconstructions, multi-layered reconstruction. Then we have moved to different reconstruction. The first 400 cases we made through one nostril, through the right nostril. Now we always make binostril approach, and we make endonasal, not parasectal. And this is our present standard. Maybe I hope to be able to speak with you in 10 years and to tell you that we have moved to a better solution.
Okay, thank you.
Maybe we'll do it, Professor Cavallo, instead of me. It's more probable.
Okay.
Thank you. I think I have one question. It's about, you talk about 3D endoscope and 4K endoscopes. What do you recommend?
Absolutely 4K. 3D for me, it was not satisfactory at all. It was a delusion, 3D. In our hands, it didn't work. 4K, it's magic because you see better. And the eyes for the surgeon are very important. If you see well, you can make well on the back.
Thank you. I ask our panelists if they have any question.
Yes.
Yes, Professor Mufid.
Good evening, everyone. Thank you, Professor Cappabianca, for your excellent talk. I have a question about the risk of carotid artery lesion during the surgery of hypopituitary adenoma in the absence of Doppler monitoring during surgery. What do you recommend to reduce the risk of carotid artery lesion?
To study the X-rays, to know the anatomy, to know what you're going to do, because there is around 4% possibility that the carotid is not covered by bone. So you have to be quiet and safe when you, in each step of the approach. And the Doppler is very, very useful because the master of pituitary surgery, that's Adyl, he says that you have to go from a carotid in the opening of the bone, from a carotid to the other, and from the superior intercavernous sinus to the inferior intercavernous sinus. In another way, in other words, Amica Sams say you have to be among the 4 blues, which means cavernous sinus, intercavernous, supracellular, circular sinus, and inferior intercavernous sinus. So if you make a proper exposition, it's good to check with the Doppler the position of the carotid. It's always safer. Some surgeons, again, Dan Kelly, does it 100% of the cases. We don't do, to be honest with you, in every cases. But if we have a lateral extension, or if we go above in extended approaches, we use the Doppler.
Thank you.
Thank you. And we have a question on the chat. Professor, what if the carotid is injured? What are the steps to follow?
First of all, you pray. Second, you make some pressure with the cottonoid and hemostatic materials. And then you go to endovascular treatment with your interventional neuroradiologist. Everyone making this kind of surgery has had a case like this in his stories, if he tells you or if he doesn't tell you. So pray, make stop the bleeding and go to the intervention.
Thank you so much. I think we don't have more questions for now. And thank you, Professor Cappabianca. And we will move to the second talk of Professor Adyl Melhaoui. And Professor Faisal Mufid, will you introduce Professor Melhaoui to our participants? Thank you.
Okay. Dear colleagues, dear friends, good evening. I am very happy to be here today. To start, it's a pleasure to participate in this learning program organized by Professor Abadi. We wish a quick recovery for her. First of all, I would like to congratulate Professor Abadi for the organization of these sessions. It's an excellent initiative that should be maintained. Now, for the second talk, it's a pleasure to introduce my friend, Professor Adyl Melhaoui. We'll talk about radiosurgical treatment of pituitary region tumor. Professor Adyl Melhaoui is a professor of neurosurgery from Mohammed V University Hospital in Rabat. Adyl is working in specialty hospital. He's also the co-director of Functional Neurosurgery and Gamma Knife Radiosurgery Unit, National Neuroscience and Rehabilitation Center in Rabat. He's also the head of the Emergency Department Specialty Hospital in Rabat. Professor Melhaoui is the treasurer of Hassan II Foundation for Prevention and Treatment of Nervous System Disease. He is graduated neurosurgery in 2008 from University of Rabat, Morocco. He spent 2 years in neurosurgery, fellowship of neurosurgery in University Libre of Brussels Erasmus Hospital, Belgium. He also spent 1 year fellowship of functional and stereotactic neurosurgery and radiosurgery in Timon Hospital, Marseille, France. Please welcome Professor Melhaoui.
Thank you. Thank you, my dear Faisal, and thank to the organizers and especially Professor Abadi for giving us this opportunity. It's sure that it's not easy to take the word after the amazing talk of our master, Professor Cappabianca, with a very huge experience with the pituitary region surgery. So my statement here is to talk about the radiosurgical treatment of pituitary region tumors. And first of all, I would like to insist on the fact that we are talking here about the knowledge that every neurosurgeon should have regarding radiosurgery for this kind of lesions. Knowing that we are all radio neurosurgeons in the team of radiosurgery of Rabat, and all the patients we are taking care of, we can offer them, we have the chance to have the endoscopy, the microsurgery, and the radiosurgery. So the 3 techniques are available in our center. And I think this is most important for every reference center to have at least the all capabilities and choose each case based on the specific situation of the patients. So if we want to go ahead, in the last decades, as you may all know, radiosurgery is nowadays widely used for treatment of several benign and malignant lesions. And this is, of course, besides surgery and medical treatment, especially in pituitary region lesions, as we will see. So I insist here on the fact that radiosurgery for us is considered only as a tool of the neurosurgeon. So when we speak about pituitary regions, as we heard from Professor Cappabianca, we are talking mainly about pituitary adenomas, craniopharyngioma, supracell meningioma, and maybe chordoma of the clivus and skull base. But my talk will be dedicated mainly to the pituitary adenoma, as it is the largest group in this region. And will say some words regarding craniopharyngiomas. So if we look at our series in Rabat, so up to 2020, we have more than 2,000 cases treated. And when we look at the pituitary adenoma, They are about 137 cases, so representing 6.5%. And the craniopharyngioma, we have around 55 cases, representing 3%. And you have here all the other pathologies that we can treat. As you may know, it covers all the field of neurosurgical conditions. So first of all, as I was saying, radiosurgery and gamma knife radiosurgery as a tool of the neurosurgeon, it must be understood that it is completely different from other techniques of radiation therapy that could be conventional radiotherapy, and it could be also conformational or what is so-called hypofractionated or hyperfractionated stereotactic radiotherapy. So stereotaxy doesn't mean radiosurgery. When we refer to the term radiosurgery, it's as defined by Lars Lexell, the inventor of the technique. It's a single high dose. So radiosurgery, gamma knife radiosurgery, is a single high dose and should be differentiated from the other irradiation technique. And you see here, there is a clear gradient in terms of precision when you compare this radiosurgery gamma knife done by the Lexell gamma knife and you compare it to other techniques mainly based on LINAC. So regarding pituitary adenoma, the role of radiosurgery is becoming more important, but it is seen for us as a complement to the gold standard, which is surgery and medical treatments. So we may give some technical aspects regarding how this technique is done. First of all, when we are treating in the pituitary region, we need to have a clear delineation of the optic pathways. So you see here on a T2 coronal MRI scan, you see very nicely the optic pathways and the sella with the lesion. And you see we have enough distance to treat safely this lesion, like here 15 grays, and you see that the safety margin for the optic nerves that is considered here as the 8th gray, the green line, is completely sparing the optic pathways. So these are some specific data we should be able to evaluate before indicating and giving our treatment. The second thing, when we are treating at the level of the skull base, our protocol before treatment include a CT scan that we give the bony delineation of the sella, as you can see here, and you are able to check that there is no shift in the given radiation. When we speak about stereotaxy, we are speaking about precision, and we need to be accurate and sure that the dose delivery is perfectly given at the right place. So when we are treating at the level of the skull base, the CT scan is very important to check that we are really accurate. As you can see here, it's the sella, the dosimetry is perfectly fitting to the sella. Another aspect is for the frame placement. When we are using frame-based techniques, we can put the frame in a plan that would be parallel to the optic pathways, as you can see here, so that when we have the scan, we can easily identify our optic nerves and be able to spare them. So this is one of the technique. The second technique to spare that optic pathways is the angulation that could be put at the head of the patient during positioning at the gamma knife before treatment. And you can see here that we can use mainly the 70-degree angle that is available. As you can see here, if you consider a treatment given at 19 degree, you see here that the isodose is crossing the optic pathway. But when you change the angle, you see here 70 gray. Now the isodose is no more crossing the pathway since it is parallel to the optic pathways. And mainly you can see here that the dose is reduced from 7.8 to 6.4 gray. This is only by changing the angle to be able to spare that optic pathways. And another useful tool that we have available in the Gamma knife, mainly since perfection, is the ability to spare and block some sectors, meaning some sources of beam, so that we can use the dynamic shaping, which is an automated generation of the dosimetry that will spare the critical structures. And here again, we are speaking about the optic pathways. As you can see in this example, we had a very small, tiny functional recurrent microadenoma, but you see here the optic pathways are within the defined isodose, marginal isodose. So using this tool, you can see here that the more we will increase this dynamic shaping, the more you can see here gradually we are sparing that optic pathways just by adjusting here this dynamic shaping, which will give a shape to the dosimetry. So we are shaping the dose so that we can spare perfectly the optic pathways. And you can see here the results. This is only possible with the latest generations of gamma knives, which allows you within less than 2 millimeters to drop the dose from a 25 gray that we will see as the useful dose and efficacy dose for functional microadenoma, and less than 3 gray, which is a fully secured isodose line for the optic pathways. So these details regarding the dosimetry are very important to know, to see what kind of lesions are safely and efficiently treatable with gamma knife radiosurgery. And also, now that we have moved, thanks to the Hassan II Foundation that is supporting our center in Rabat, we have moved in 2017 from the gamma knife perfection to the new gamma knife icon. And with the gamma knife icon, it is also possible nowadays to have fractionation of the dose, and this makes us go even further in terms of sparing of the optic pathways, since that when we have the nerves that are within the volume to be treated, we can then go for a fractionation of the dose that will be more efficient on the sparing of the nerve, of course, keeping the efficiency of the treatment. So what are the usual indications of radiosurgery in pituitary adenoma? Usually, it is a small postoperative residue, and mainly those within the cavernous sinus. As I told you in the introduction, we have the chance to be in a team that fully and routinely performs the transperineal approaches with the different techniques, endoscopy, microsurgery for this pituitary adenoma. So all our patients are treated by surgery as first line. And this radiosurgery is for us an adjunct for selected cases when there are residue, mainly in the cavernous sinus. As we know that surgery within the cavernous sinus can induce some consequence for the patients. And as we are aiming to the less invasive approach, most of this extension would be left for a complementary radiosurgery. Of course, I have mentioned all the technical aspects we may have to spare the optic pathways, but nonetheless, we must have a fully decompressed optic pathways, or at least non-symptomatic visual compression, meaning that the patient, if the vision is at risk, of course, we have and we need to decompress the optic pathways first. So surgery is the first step, no discussion on this. When there is secretin residue, meaning that it is a functional pituitary adenoma that surgery could not cure, and we know all of us that in the statistics, it's up to 30% of the cases that could not be cured by surgery, and then we will need other complementary treatment, either medical, but as we will see, radiosurgery also can be very effective. In cases of recurrence, we all know that second surgeries can be quite tricky, and sometimes if we consider the risk for a second surgery compared to the low risk in a radiosurgery treatment, we may discuss with the patients and other colleagues what can be the best suitable option in every case. We have very rare contraindications for surgeries, but I think within the 135 cases, we had only one case that could not undergo general anesthesia, where we discussed radiosurgery upfront, but usually this is very rare situation. There are other rare cases, but well-tolerated large lesions or large post-operative residue that we have treated, especially with the icon, and we will give some words regarding these large lesions. But the classical indication is a small postoperative residue. Of course, as any technique, radiosurgery cannot be the magical solution for everything. So as any other technique, we must know the indication, know the specification, the technical limitation, and there are limits. So, of course, in any case of increased intracranial pressure, as I said, mass effects on the optic apparatus, on the brainstem, on the lung tracts, in case of hydrocephalus or hormonal status, that needs to be solved immediately. It's only surgery that can be the approach. You must know, and maybe we need to insist that radiosurgery, the action of radiosurgery, of radiation, will be delayed in time. So anything that is an emergency to be treated will not be indication for radiosurgery. Here we are speaking only about cases of recurrence or cases that we may wait for this delay to be efficient with no harm for the patient. But all other emergency cases, they must undergo surgery as first approach, and this is, of course, what we do here. Some examples. This is a 31-year-old male with growth hormone macroadenoma and acromegaly. The patient was, as you can see, operated through transphenidal approach 2008 with complete removal, but had a recurrence on MRI and with the biology with increase of the IGF-1. Here you can see the preoperative MRI. As you can see, some compression, and this is 1 year after surgery. As you can see, the patient has, excuse me, so the patient has this small residue here within the cavernous sinus, but with functional activity. So we decided to go, as you can see here, the planning. So that was 3.4 cubic centimeters treated at the 24 grays to the 50% isodose line. As you can see here, we are far from the optic pathway, so we can give the full dose. And you can see here, 8 grays is not touching the optic pathways since we are far from them. And these are the results. You can see within 1 year, significant volume reduction that correlated with the clinical improvement of the endocrine syndrome. And we are now 8 years late following these patients, and he had not had any recurrence. So again, another case, as I told you, when we have functional secretin adenoma, we need to give quite high dose, 25 grays also in this growth hormone secretin, but again, we can spare perfectly the optic pathways staying lower than 8 grays. So this is almost 0% risk to have any neuropathy. Other examples of volume respond 1 year after radiosurgery of this pituitary. So what about, I told you, when we have quite large non-secretin pituitary adenoma, we need to have and keep in mind that the larger is the lesion, the lower will be the response rate. So we will insist about the size and need a small size. It's to have more than 90% response and control. But in the large lesions, we can still be effective as low as 9 grays. The classical dose is around 15, and we can keep the response rate higher than 70%. Volume, of course, is a problem because sometimes, as I told you, for functional lesions, we need between 24 and 30 gray. So there is some risk of toxicity in larger volume. And there is also a correlation between the volume and the secretion rate. So the larger is the lesion, the lower will be the response rate. Anyway, in this kind of situation, there is an advocacy for radiosurgery because it's better than the radiation therapy. In our group, we consider that for benign lesions in young patients, we should absolutely avoid radiation therapy because the risk of oncogenesis at long term is 10% for radiation therapy, where there is absolutely no increased risk with the radiosurgery. There is higher risk for optic pathways, and we have seen that radiosurgery is absolutely able in one single dose to spare the optic pathways. There are high risk mainly for brain cognitive function to be deteriorated by the radiation therapy, while this is not the case with the gamma knife radiosurgery because it is a selective irradiation. We also avoid all others side effects related to radiation therapy, such as fatigue, hair loss, and many others. So radiosurgery is more effective in tumor control and secretion control than radiotherapy. And so the message here is to avoid to give any radiation therapy in case of residual or recurrent benign tumor, but think about offering the patient radiosurgery, which is a more neurosurgical tool again. So concerning the response to radiosurgery for pituitary adenoma, usually we have a very good and regular response regarding the growth of the tumor. We are talking here about more than 90% control rates in any series, and we have the same here in Rabat, as we will see. The problem will be the hormonal oversecretion. So as we can see, growth hormone and cortisol Cushing disease tend to respond more than prolactin. And fortunately for prolactinoma, we have the medical treatment. It's less easy with the first two cases. Here we can see meta-analysis about, as I told you, all the cases, all the series are showing more than 90% control regarding the growth of the tumor. So since it is benign tumors, when we treat them with radiosurgery, we have almost no problem to control them from the volumetric point of view. The problem, as I told you, is the response regarding the secretion. And you can see here, when we are talking about acromegaly, we have response rates that are largely variable between the series. It goes from 15 to 100%. But the mean control rate will be around 70%. And most important is that the delay that we need to have this response. The mean follow-up to have the final response we consider is to go up to 5 years before stating about the response. In large cases, as I told you, so this is an example of a large residue after surgery, but with combination of radiosurgery and medical treatment, we could achieve that kind of results within 2 years, which is almost a complete disappearance of the lesion. But again, these are highly selected cases. So as any technique, we may talk about some complications. As I told you, if we are strict in the indications and we respect the technique, we should not have any visual deterioration. So as long as we are less than 12 gray to the optic nerve, we should have less than 1% risk. In our patients, we almost have no visual deterioration just because we are applying this rule. The other neuropathies, mainly within the cavernous sinus, there is a risk, but it is low, depending on the dose you give. As you can see, if the dose is around 80 gray, you can have up to 10%, but for the low dose, between 11 and 12, again, you have less than 1%. So if we are in a functional macroadenoma, we may have some risk, but in non-functional, there is almost no risk. Another aspect is, as I told you, we are judging the final results at 5 years, and at 5 years for secreting adenoma that we are giving higher than 20 gray, we can have up to 30% new endocrinological deficit. But of course, the endocrinologists can deal better with this complication than the hypersecretion. And again, compared to radiation therapy, we have less than 1% risk of brain toxicity. I would say if the radiosurgery is done properly, you should not have any brain toxicity. There is no risk, as I said, of induced malignancy. And again, as we are working in a neurosurgical group, if there is any tumor growth or failure that can go up to 5 to 10%, again, microsurgery is here and should be used to treat those patients. So for pituitary adenoma, as I said, radiosurgery is the gold standard. But Lexel gamma knife radiosurgery should be included in the armamentarium of the neurosurgeon as a tool in a multimodal management for these cases that need it, and for cases of persistent of recurrent pituitary adenoma. And again, radiation therapy should be fully abandoned. So just some words regarding craniopharyngioma. We compared to pituitary adenoma, this is a more complex topic. And here in our group, more than in the pituitary adenoma, the multimodality approach is the rule, I would say. So again, if the surgery is the first approach, radiosurgery, since it is a benign lesion, can be very effective. And if craniopharyngioma is considered from the radiotherapy point of view as radioresistant tumor, in radiosurgery, it appears to be a highly and extremely responder tumor, because it can respond to doses as low as 9 gray. And you can see here some examples of some recurrent craniopharyngioma This is a recurrent intracellular craniopharyngioma that has been operated first transsphenoidally, and then since it was a recurrence, we went for radiosurgical treatment, and you can see here the results 1 year after. And again, this patient is followed more than 6 years with no recurrence. Another example, just to show you here, when it is involvement of the cavernous sinus, we are not far from the optic pathways, but we can treat safely this patient with no visual, and we have even some decompression after volume reduction. Again, here, the same thing, you can see that with radiosurgery, you can fully identify your optic pathway and treat it, even if you are really close, but you can perfectly spare it thanks to the technical capabilities of the gamma knife. So just some conclusion about craniopharyngioma. As I said, radiosurgery is a second intention therapy. Surgery is the gold standard and should be used as first approach as soon as there is compression of the visual pathways, and the technique of radiosurgery has lower complication compared to other radiation therapy. This is the main message. Neurosurgeons should know what are the complications of every technique, and as I said, gamma knife radiosurgery is part of the armamentarium of the multimodal management of craniopharyngioma, and I thank you for your attention.
Thank you, Adyl, Professor Melhaoui, for this brilliant talk as always. And I will let Beverly and Faisal to manage the discussion parts.
Thank you very much, Ahmed. Thank you for a very brilliant talk. Professor Melhaoui, may I kindly ask, at what stage do you think a neurosurgeon in training should gain exposure to principles of radiosurgery?
Very good question. Thank you, because in our center, as we are a teaching hospital, this is one of the subjects we fully discuss. We have the chance with Professor Abbadi to rule stereotaxy certificate given by our university, because for us, radiosurgery and gamma knife radiosurgery is just a part of the stereotaxy of the functional neurosurgery approach. So this certificate usually is undertaken by fully trained neurosurgeons, or at least those who are at 5 years of residency, meaning they have almost fulfilled their training. So it is not the basic thing to learn. But in our department, since we are practicing stereotaxy, the residents, since they are young, they can be exposed to the practice of stereotaxy, because radiosurgery is not just stereotaxy applied to radiation therapy. So it's very important for the young to be exposed to these basics from the start. But of course, to go further, they need a fellowship. They need to go even further. And I think Professor Khamnishi is here, and with all the team in Rabat, we had the chance also with the Gamma Knife Society to have a collaboration for fellowships for the colleagues who want to join the team, just to train in this specific, I would say, chapter of neurosurgery, because it needs a lot of exposure as any other techniques. We are insisting on this, that it is just as any other techniques of neurosurgery. Thank you for your question.
Because you have a background in quite extensive training in functional and other things, the utilization of radiosurgery applies to very many branches of neurosurgery. So skull-based, vascular, functional, pain. Do you think that somebody should choose a particular pathway before they can do radiosurgery? Say, for example, like yourself, functional, or which directions should someone take?
Again, it will depend on the situation of every center. We have the chance in the center of Rabat with Professor Khamishi, Professor Wahabi, and all the colleagues. We have almost 30 years of microsurgery and high-level neurosurgery. So when the radiosurgery came in 2008, we had still a long history of practice of neurosurgery, and it has been implanted in this multidisciplinary approach. So we are able to offer the patients any of the approach. So it should not be isolated. If there is to be a program, it should be included in a university approach that all the other colleagues can support you, because you cannot be alone. So whenever there is a group, I think one of the colleagues, if the group is enough, I would say large, one of the colleagues can take the lead and develop the functional neurosurgery, because we need it also this part of the practice. Many patients need it a lot.
Thank you. If I could go to Prof.
Just for add something, we always said that the radiosurgery is complementary tool, not competitive. Just to add that Professor Melhaoui said, it's you need the multidisciplinary that of course have a master in many chapters of neurosurgery. I mean, skull-based, functional, and the radiosurgery will be here as a complementary tool, not competitive. Thank you.
Thank you, Prof. There's a question.
Okay. I think there's a comment of Professor Khamishi.
Yes. Good evening, everybody. You hear me?
Yes.
Yes.
Yeah. Sorry for arriving quite late. Good evening, my dear Paolo. I'm so sorry. I couldn't attend all your conference, but I'm very happy to welcome you and to see you here. I hope we will see each other in person and with all other colleagues. Adyl, the question raised regarding training is very important, I think, because it allows me to make two comments. The first one, that all young neurosurgeons should know that radiosurgery is a neurosurgical technique. And it's not only, I mean, a problem of enlarging the speciality. It's the problem of the efficiency and the interest for the patients. Radiosurgery cannot be practiced outside the Department of Neurosurgery, outside, as you said, a very good background and training in microsurgery, and also outside a high knowledge and practice of brain surgery, brain anatomy, and so on. So we have chance, I think, or young colleagues, mainly young African colleagues, have a very, very good chance with this gamma knife unit in Rabat, because you know that we have, of course, the WFNS Rabat training program, where many young colleagues are trained. So all of them become aware about the importance of radiosurgery. They go to the unit, they discuss the cases, they see how it works. But also there are these fellowship coming from the European Society of Gamma Knife Radiosurgery, but also coming from a Moroccan institution, which is the International Agency which is the Moroccan Agency, for International Cooperation. So there are possibility for training of young neurosurgeons in this specialty.
One question, Professor Melhaoui.
Yes, of course.
Thank you for this nice presentation. I have one question in your daily practice after pituitary adenoma surgery. You perform three techniques. In the case of partial tumor removal, do you recommend a second surgery or move directly to radiosurgery?
I think the question of the second surgery depends on the surgeon and the patient. If the surgeon thinks that he can do better with the second surgery and the patient is accepting that, of course, this is the first option to discuss. But then if you have a residue or you could not achieve a complete resection because of some difficulties, and as a surgeon, you know that you cannot do better, I think radiosurgery is then an option, and it is better than a simple follow-up if the patient is young, because if the patient is young, you cannot just follow him, the tumor will recur. If we are speaking about 80-year-old patient that you have decompressed the optic pathways, he's doing well, and he has some remnant in the cavernous sinus, of course you can choose to follow. But if it is a 13-year or 40-year, you cannot. You need to then propose some treatments. So it will depend on your approach. If you think you could achieve better, of course you can go ahead. But if the first surgery was, I mean, there were some difficulties like lateral extent or something that stopped you from doing a total removal, then what to do with the remnant? We think if the patient is young, he should be offered a complementary treatment.
Thank you, Adyl.
Welcome, my friend.
Maybe, may I have a comment about that? I think that all of you knows very well that the stellar region tumors are my favorite practice, and I would like to add, my dear Mufid, that this surgery needs some experience. And I think we have to think on the remnant tumor and on the recurrent tumors before the first surgery, because most of these remnant tumors or most of the recurrence depend on the quality of the first surgery. It's very, very important to know. Today, we have also, in addition to the microscope and microsurgery, we have the endoscope. And I think that our colleague, Paolo Cappabianca, has already said a lot about that. So we have to gather all good conditions for the patients before the first surgery, and then perform this first surgery. You get maximum chance to get out all your tumor and to have, of course, a minimum recurrence. But I think in case of a recurrence, if the recurrence is small, and especially if it's non-functioning adenoma, which needs a lower dose of irradiation, radiosurgery can be preferred if the patient has to be operated in the same conditions as in the first surgery. Because if we couldn't make a total removal in the first surgery, if we come back with the same conditions, I think we will not perform a total removal. So this should be very clear, and it's very important to precise that. We have to think on our patients.
Thank you.
Professor Cappabianca maybe had a comment.
I agree with both considerations you and Professor El Kamlishi have done. I completely agree. And I find a question here that how often we need radiosurgery. I do not have a percentage on our patients, but the rationale is just what you and Professor Kamlishi have said. So there are centers where you have adequate caseload, and if you are satisfied by your surgery and the conditions you have said, but we use radiosurgery when optic pathways are at least 5 millimeters, I would say, far from the tumor. And when there is lateral extension, we have not been able, or we cannot make radical removal over there. These are the two main conditions.
Yeah, so I mean, it will go to the rate of total removal. If you go to the literature, I think total removal for non-secretin will be between 80 to 90%. So we are talking here about residue after surgery. If we go to the functional ones, you know that in the literature, the cure after surgery is around 70 to 80%. So we are talking about the 20 or 30% that are remaining. I don't know, Professor Cappabianca, your numbers are more or less the same, but this is the mean of the literature.
Yeah, but depends on the behavior of the tumor, which is not always the same. So a careful follow-up and the team approach with the different professionals, obviously including the radiosurgery, endocrinologist, neurosurgeon, it's crucial. And we can decide all together the best option for the patient.
Thank you.
Sorry, may I ask a question?
Yes, please.
Go ahead.
Yes, Professor Vinsgumot, go ahead.
Yes, go ahead. Go ahead.
Thank you. First of all, I would like to thank the two speakers for their wonderful presentation. You know, pituitary adenomas is a special tumor with huge particularities regarding extension and invasiveness with neighboring structures. We've heard beautiful things regarding the efficacy and the indication of radiosurgery in this kind of tumors. I would like to ask two questions. The first one is when radiosurgery seems to do not work in this kind of tumors, and when we decide to send the patient to radiosurgery, does it mean that surgery is over, or we can reoperate many years or after the patient being treated by radiosurgery? And in that case, what are the difficulties of such surgery after radiosurgery? Thank you.
So I will answer the first question, if I did not forget it already. So it was about what are the criteria for the response. I think it's just as Professor Cappabianca said before, there are some histological behaviors that may or will influence the response. So as long as your tumor is truly a benign tumor, the response rate will be good. But we had, in these 135 cases, we had one case that has recurred, and the pathologists find that it is a quite aggressive lesion. So we can have some histological patterns. So the most important thing is the histology. But fortunately, in the pituitary tumors, these aggressive types are really like not more than 1-2%. So they are really rare. Most of them, they respond. And as I showed you in the literature, you have between 90 and 100% control rates. So it means these are benign tumors, and benign tumors will respond very well from the growth control rate. So this is not a problem. When you have this 5% of tumors that are not responding, microsurgery is, of course, an option. And this is why it is important that this technique is practiced by the neurosurgeons. It will give you the ability for those who do not respond to come back and do microsurgery. And the question you arise, I think, is coming from the data we have from the radiation therapy experience, as it is reported that after radiation therapy, surgery can be quite complicated because of the adherence and so on. Since radiosurgery is a different technique, all the reports from even experienced neurosurgeons, and if I take the cases that has been treated by our team, the surgery after non-response after radiosurgery is not more complicated than a first surgery. So there are no fibrosis or any other such expected modifications of the tumors that you may expect from the radiosurgery, which is not which is completely different from radiation therapy. So your question is very right from this point of view. But again, radiosurgery is very different from radiation therapy. So the results are different. So you may operate in a case of failure after radiosurgery, no problem.
Thank you.
Thank you so much, Adyl. And I think that we don't have any more question from the floor or from, I don't know, from the speakers or panelists. Just let me to say that we have more than 600 registered participants for the second part of Morocco webinar series, and we had more than 1,600 participants during the last 12 webinar from more than 50 country. So thanks to all participants from all over from the 5 continents, and to all 90 faculty from many present in many countries, many societies, and many universities around the world, experts and young neurosurgeon. Just we had the pleasure to meet during this hard period of COVID-19, and to share science and to learn more from our from speakers, experts, and from each other, to move on and to be prepared for the next year without COVID-19, I hope. I will ask Professor Abdelhakim Al-Khdar to give a word, I think last word of the webinar before, I don't know if Professor Najila Al-Badi will give a word too. She's, we hope for her to be well for the next meetings. And Professor Al-Khdar, you have the mic. Professor Cappabianca and Professor Adyl Melhaoui, Professor Mufi, and Professor Beverly for your participation. And thank you. Professor Khdar, you have the last word. Thank you.
Thank you. Thank you, Professor Cappabianca, for your very interesting talk. You are the pioneer of skull-based endoscopic surgery, mainly the pituitary surgery, endoscopic pituitary surgery. Thank you for sharing your very wide experience in this field with the Moroccan community, the Moroccan neurosurgical community. Thank you, Professor Adyl Melhaoui, for your talk about radiosurgery in pituitary adenoma in some difficult and challenging cases that we face in our practice. Thank you, Professor Cesarem, our young professor assistant in Nairobi. and co-chair of the Education Committee of Young African Neurosurgeon and member of the young neurosurgeon in WFNS. Thank you for your very important animation of the discussion, and also my friend and colleague, Professor Mufid, the head of the Department of Neurosurgery in Wajda, for the animation of the discussion. And thank you, Professor Abbadi, for having maintained this program of webinar. Very hard work, I know. It was a weekly, almost every week, every Thursday. And thank you and congratulations for maintaining this program despite the difficult and very difficult conditions. It was very hard. Thank you, Dr. Darqawi, for all the efforts you have done during this period. And I hope we will continue this program, but not at the same rhythm. I know it's very, very hard. Thank you for all our guests of our for all the speakers, for all the guest speakers and panelists to be present with us in all these stations. Thank you. And I don't know if Professor Abbadi, she could give some words. I hope she could.
I will try because it's very important. This is the last webinar, and I would like to of course thank all the Moroccan society and all the members of the administrative council of the Moroccan society to give me this opportunity to organize with my team this series of webinar. And we are lucky, and we have a lot of chance to have many experts around the world from the 5 continents, as Dr. Darqawi said, and also many panelists from different continents, usually younger than the speakers, and all the discussions were very interesting and very patient. And we had many messages from many continents, many neurosurgeons about this series of webinar. I think it's, in my opinion, we succeed our task because we continue even this hard time, the education of our resident, not only Moroccan resident, but Sub-Saharan African, and also all the Arab area, French speaking, and around the world. You remark many times that we have many participants from the 5 continents, and for that I'm really grateful for all the participants during this hard time and for this 34th webinar. Thank you so much for participating, for enriching this series of webinar, and we promise you that we will continue in the next year, hoping that this pandemic will get better, and we can see each other personally and continue the education of our young neurosurgeons. Thank you so much for all of the team that organized this webinar, particularly Dr. Darqawi, who is working very hard to prepare every week this webinar, technically, but not also technically, also by contacting with me all the speakers and the panelists, and choosing also the different speakers in the same field. Thank you also for some pioneers in Morocco to support this program, particularly, of course, all the Moroccan society, but especially some seniors such as Professor Khamnishi, Professor Azhari, also from Algeria as Professor Khairuddin, There were always with us for 34 webinar. Thank you so much, and I hope see you soon. See you soon in not in virtual mode, but physically. Thank you so much.
Thank you.
Thank you. Bye.
Bye, everyone.
Bye. Stay safe.
And see you next Thursday for the online annual Moroccan Congress of Neurosurgery next Thursday at 4 p.m. Morocco time. See you next Thursday. Bye-bye.
See you. Bye. Moroccan.
And don't forget also the French speaking society. We are all the member of the society,
Yes.
and
On Saturday, yes.
we will have in 2 days the
Sunday.
meetings. Okay.
Saturday.
So
Saturday,
bye
yeah.
everybody, and take care.
Bye-bye.
See you. Bye.
Bye.